Okay, my presentation today about general topic in recent modalities and hormonal replacement therapy. I am Dr. Walid Tawfik, Assistant Professor of Obstetric and Gynecology, Banana University, consultant of IVF and endoscopic surgery. My topic today will cover the following items: stage of reproductive aging, defining perimenopause and menopause, global consensus on the use of menopausal hormone therapy, benefits and the risk of menopausal hormone therapy, contraindication, side effects, how to prescribe MHT, and finally recommendation. Stage of reproductive aging is the first standardized classification guidelines of female reproductive aging. It has 7 stages. The main landmark of this staging system is the final menstrual period. Our region of interest is stage -1, -2, which represent menopause transition, and stage +1 and +2, which represent post-menopausal period. Premenopause marks the beginning of menopause transition, starting with menstrual irregularity more than 7 days between consecutive cycles, leading up to the last menstrual period and continuing for 12 months after that. Menopause refers to a point of time that follows 1 year after permanent cessation of menstruation. Perimenopausal and menopausal women may experience and seek treatment for a variety of symptoms related to estrogen deficiency. Hormonal replacement therapy is a broad term used to describe both unopposed estrogen used for women undergone hysterectomy and both combined estrogen and progesterone for women with intact uterus. Hormonal replacement therapy is a past term. Nowadays, menopausal hormone therapy replaces hormonal replacement therapy. The use of menopausal hormone therapy decreased by about 80% after the initial publication of Women Health Initiative study results in 2002, which was shocking results, as it shows that hormonal replacement therapy increases the risk of coronary heart disease, breast cancer, venous thromboembolism in women using MHT. However, after subgroup analysis, according to age group, and after 18 years follow-up of WHI study, and with recent RCTs like KEPS study and ELITE study, it shows a safety profile when start early in menopause within 10 years or in women less than 60 years. Global consensus in the use of MHT. The following consensus statement is endorsed by many of menopausal society all over the world, which is American Society of Reproductive Medicine, Asian Pacific Menopause Federation, Endocrine Society, the European Menopause and Andropause Society, International Menopause Society, International Osteoporosis Foundation, and North American Menopause Society. It states that the principal indication of MHT is to alleviate vasomotor symptoms. MHT should be a part of overall strategy aimed at improving midlife health. Estrogen only appropriate for women with after hysterectomy. Progesterone should be added for production of endometrium in women with intact uterus. Local MHT is preferred when symptoms are confined to lower genital tract. Current safety data don't support use of MHT in women with breast cancer survivor. As regards the benefit and risk, the first benefit is the vasomotor symptoms, which is a common indication of menopausal hormone therapy. Estrogen is the most effective treatment for vasomotor symptoms. It reduces a hot flush by about 70%, both frequency and attitude. It is only approved by FDA for this indication. As regards the osteoporosis, estrogen reduces osteoporosis-related fracture by about 50% when start early in menopause and continuing for a long time. It also reduces fracture in women with established disease. However, this preventive effect loses rapidly after discontinuation of treatment. As regards coronary heart disease, recent RCT showed that estrogen has a favorable or neutral effect on coronary heart disease and coronary vascular disease risk when started early in menopause within 10 years of menopause or on women with less than 60 years. However, the formulation and the type of estrogen and the route of estrogen may differ the effect and the adverse effect on coronary heart disease. As regards stroke and venous thromboembolism, both estrogen and progesterone increase the risk of stroke and venous thromboembolism, not dependent on age or time since menopause. Hormonal replacement therapy also reduces the risk of type 2 diabetes, reduce fasting blood sugar, reducing hemoglobin A1C, and improve insulin resistance. As regards breast cancer, estrogen alone in the form of oral conjugated equine estrogen reduces the risk of breast cancer. Addition of progesterone with estrogen increases the risk of breast cancer, but not breast cancer mortality. As we know that estrogen increases the risk of endometrial cancer, progesterone should be added for protection of endometrium. Postmenopausal woman has 1.5 times more risk of cancer colon as compared to the menopausal woman. Estrogen plus progesterone reduces the risk of cancer colon. However, estrogen alone doesn't decrease the risk. All-cause mortality trend towards decreased risk when started early in menopause, within 10 years of menopause, or in women less than 60, decrease in all-cause mortality. What is the contraindication of MHT? Known or suspected estrogen-dependent malignancy, breast cancer current or suspected, undiagnosed vaginal bleeding, untreated endometrial hyperplasia, current thromboembolic event or myocardial infarction, untreated hypertension, active liver disease, non-intolerance to certain preparation. What is the potential adverse effect of MHT? It should be may be short-term as breast tenderness, fluid retention, bloating, and headache, and this is related to the dose. Start with low dose and the choice of regimen. Vaginal bloating and bleeding, which is very common in the first 6 months of therapy, especially with continuous combined estrogen and progesterone therapy. Long term, as a thromboembolic event, it increases with oral, not with transdermal therapy. Breast cancer influenced by dose, duration of therapy, and the choice of progesterone. How to choosing the right MHT? Is my patient candidate for this? Please, the clinical indications should consider each severity of symptoms, benefits and risk, and contraindication. Hot flush is the most common indication and should start early in menopause. Mod liability and depression, MHT alone is an indication, plus or minus selective serotonin reuptake inhibitor. Sleep disturbance treated to nightmares, hot flush, coexisting depression and anxiety, joint aches and pain, vulvovaginal atrophy, and here we use low dose vaginal rather than systemic estrogen. Hormonal replacement therapy no longer indicated for prevention of coronary disease like coronary heart disease, osteoporosis, cognitive function, and prevention of dementia. However, British Menopause Society and Women Health Concern in 2020 indicates that HRT should be considered the first line of therapeutic intervention for prevention and treatment of osteoporosis in women with premature ovarian insufficiency. Preparation of MHT estrogen preparation. First, systemic oral. It has a unique advantage of first hepatic bus effect. It increases hepatic protein production like steroid binding globulin, corticosteroid binding globulin, and sex hormone binding globulin. Increase HDL and the clotting factor. Transdermal patch, it avoids first blood effect, has a less risk of venous thromboembolism and stroke. However, it causes skin irritation in about 30% of patients. Topical like gel, lotion, spray, subcutaneous implant, and subcutaneous fat of anterior abdominal wall using special trocar. Vaginal, either vaginal ring, which is a high dose estrogen for hot flush, or low dose cream or tablet for genital syndrome of menopause. Choosing the right MHT option for perimenopausal woman. First, we can start with continuous estrogen sequential progesterone is the best option for women over 45 years. We commence with estrogen on the first day of natural cycle and start the progesterone for 14 days of cycle. It doesn't control PMS. Transdermal option is available. Estrogen progesterone contraception. We can use a low dose estrogen contraception in the form of 20 microgram saline estradiol, like ES, and 40 unless contraindicated, like obese patient or smoking, as it increases the risk of stroke and venous thromboembolism. It can control PMS, has a good cycle control. We use low dose estradiol. Continuous estrogen plus levonorgestrel intrauterine system is an option for this woman. It causes no bleeding, but it doesn't control PMS. Transdermal option is also available. Continuous estrogen plus continuous progesterone likely to cause irregular bleeding in the first 6 months. PMS may still occur, suitable for some women who can't tolerate side effect of progesterone. As in continuous estrogen, continuous progesterone therapy regimen, we can use low dose progesterone. Choosing the right MHT for post-menopausal women. With intact uterus, we can use combined transdermal patch estrogen plus progesterone, transdermal estrogen patch or gel plus oral progesterone or levonorgestrel intrauterine device, oral estrogen plus oral progesterone or levonorgestrel intrauterine system, Tibolone, which is only available in Egypt here, estrogen plus serum selective estrogen receptor modulator, which is a tissue selective estrogen complex, and finally estrogen implant plus oral progesterone or levonorgestrel intrauterine device and need specialist referral. For post-hysterectomy, no need for progesterone protection, so we can use transdermal estrogen patch or gel, oral estrogen, Tibolone, estrogen implant, specialist referral. We here show a menopausal hormone therapy dosing and route of estrogen. We have different estrogen preparation like oral conjugated equine estrogen, 17 beta estradiol, estradiol valerate, transdermal estradiol patch, and estradiol hemihydrate gel. We can classify into start with low dose, increase the dose gradually to reach the high dose to alleviate symptoms. Younger women may require higher dose and vice versa. As regards to progesterone, we can use dydrogesterone like dofaston, medroxyprogesterone acetate, noracetone acetate, micronized progesterone, or levonorgestrel intrauterine system. It is recommended for women with intact uterus. Different groups have different side effects. If a problem with one combination, change with one with different progesterone. Continuous progesterone can cause continuous progesterone should allow use of low dose progesterone, and this may reduce side effects. Tibolone, it is a selective tissue estrogenic activity regulator, which is called STIR. Estrogenic activity is present mainly in brain, vagina, and bone. In active form, predominant in the endometrium and the breast. It is marketed as Lavial, dose 2.5 milligram daily, or we can use half dose with no measured loss of efficacy. Benefit, it reduces vasomotor symptoms but less than effective than estrogen. It improves bone mineral density, has a modest effect in sexual function symptoms. Risk, it increases the risk of stroke, but no difference in coronary heart disease and venous thromboembolism. No increase in mammographic density or frequency of follow-up. Increase the risk of breast cancer recurrence in patients with personal history, but it doesn't increase the risk of breast cancer at all. Has a better bleeding profile that combines continuous estrogen and progesterone. These are guidelines titled by Fetitel in 2020, published in Menopausal Hormone Therapy Latest Development. It is a guidelines of hormone administration when they refer to Tibolone to menopausal hormone therapy in post-menopausal women with acute climacteric syndrome, with lower sexual appetite or sexual dysfunction, mood swing, accelerated bone loss, osteoporosis prevention during the early menopausal period, anamnesis of premenopausal nostalgia and breast tension, high breast density, myomas, and urogenital problem. When to transfer from MHT to Tibolone, a patient with nostalgia or breast tension, increased breast density with need to repeat a mammograph or when mammogram is unreliable, mood swing, and sexual appetite disorder, irregular bleeding without a histopathological finding, in women without acute climacteric syndrome with lower sexual appetite, mood swing, osteopenia. In younger women, possibly used in premature ovarian failure or backup therapy with generation agonist. Finally, tissue-selective estrogen complex pair a selective estrogen receptor mediator with estrogen. FDA approved the medication marketed as DURV. It combined 20 mg of vasodoxifene, which is a selective estrogen receptor modulator, with 0.45 mg of oral conjugated equine estrogen for the use in postmenopausal women with intact uterus. It is used for moderate to severe vasomotor symptoms and for prevention of osteoporosis. As compared to placebo, tissue-selective estrogen complex has a similar profile in that it didn't increase breast tenderness, breast density, or endometrial thickness. Amenorrhea present in about 80-30% of uses. It hasn't been studied as regarding its ability to provide breast cancer risk reduction. Study not recommended. Compounded by identical hormone isn't recommended for menopausal hormone therapy. American College of Obstetric Gynecology and Endocrine Society advising against their use, as there is many approved formulation of menopausal hormone therapy and no RCTs for efficacy or safety of these products. Routine use of testosterone therapy, the level of endogenous androgen doesn't predict sexual function for women. Follow-up and monitoring. As regard to dose adjustment, start with low dose, titrated up to relieve symptoms. Start with high dose in patients with severe symptoms, in 40s years, in premature ovarian insufficiency. Factor affecting oral estrogen metabolism. In patients using anticonvulsant drugs, need to increase the dose of estrogen, as anticonvulsant drugs increase the metabolism of estrogen, increase the estrogen metabolism by the liver, or use transdermal estrogen, which bypass first hepatic metabolism. In patients using thyroxine, estrogen increase thyroxine binding globulin, so we need to increase the level of thyroxine. Other alcohol shows threefold increase in estrogen level. Need to stop alcohol in patients with end-stage kidney disease. Need to monitoring for decrease the excretion of estrogen. Monitoring by mammogram and endometrial thickness is mandatory. Duration of use, the standard recommendation 5 years or less, and not beyond the age of 60. The extended use of menopausal hormone therapy in North American Menopausal Society, British Menopausal Society, and the American College of Obstetrics and Gynecology agree that the use of menopausal hormone therapy should be individualized. Benefit outweigh risk. When to stop? 50% stop after 1 year of use, and this is wrong. We should use for menopausal symptoms, especially for vasomotor symptoms, for at least 5 years to avoid the return. Tapering data regarding strategy of abrupt cessation of menopausal hormone therapy versus tapering is conflicting. However, gradual tapering may limit recurrence as compared to with abrupt stopping. Special population, in patients with premature ovarian insufficiency, start with menopausal hormone therapy early and continue till average age of menopause. Reduce the risk of coronary heart disease, stroke, osteoporosis, and dementia. As regards breast cancer patient, also often experience early menopause due to adjuvant chemotherapy. Menopausal hormone therapy shouldn't be prescribed. Patients with history of ovarian or endometrial cancer, offer menopausal hormone therapy in low-risk young women. Offer non-hormonal option for intermediate and high-risk women. Finally, recommendation, British Menopausal Society and Women's Health Concern 2020 recommendation on menopausal hormone therapy in menopausal women. All women should be able to access advice on how they can optimize their menopause transition and the year beyond. There should be a holistic and individualized approach in assessing and advising women with particular reference to lifestyle advice and dietary modification. Thank you.